I thank you guys all for being here. It means so much to us, and a nice way to honor Isabelle. I'm just going to tell you a little bit about Isabelle, family, and just a little bit about our thoughts. March is a bittersweet month for us. On March 24th is Isabelle's birthday. We were thrilled that our growing family now included 2 beautiful girls when she was born. Isabelle was born with pseudo-obstruction and a mitochondrial disorder that required extensive medical care, including a multivisceral transplant and 2 years later, a kidney transplant. The hospital became her home away from home, and the doctors, nurses, aides, and other hospital staff all became like family. As you can see in some of the pictures, they were not just medical caregivers, they were confidants. They were most of all friends, and made it more heartbreaking that when Isabelle died following a medical error. This year, the focus is on sepsis, and the only takeaway that I have on sepsis is please listen to your patients, no matter how old they are, and their family members. A patient cannot be symptomatic, but know something is not right, and they're trying to explain this to you. Please do not dismiss their concerns. We, as a family, had this happen a few times while leaving appointments. Isabelle kept telling them, something is not right. I do not feel well, but she had no symptoms. Other like, fevers or anything else that would think that she was going into sepsis. On 2 occasions, we were actually leaving the hospital and she crashed at the hospital. The one time she ended up on the oscillator in the ICU and had to learn to walk and talk again. And then another time, she did the same thing here, leaving clinic, and she crashed and spent many weeks in the ICU here. So we got to know the transplant staff very, very well, waiting for a transplant. This patient safety conference is held each year in Izzy's memory. While the pain and sadness of Izzy will never go away, I find a comfort in the ongoing efforts to help prevent the senseless deaths of patients due to medical errors. I think about Isabelle a lot, and Izzy would be proud of this annual patient safety conference and knowing that she is making a difference. She would love her new little niece, Stella, who will be 1 in a couple weeks. She won't get to see her other sister, Ari, graduate high school or go off to college. And above all, Izzy would be so proud of her big sister, Maddie, who lives her life in the most impressive way as a daughter, as a wife to Eric, as a mom to Stella, as a sister to Izzy and Ari, and as a nurse. And most importantly, she was my living kidney donor a month ago today. Maddie is my hero. It is my honor to introduce Madeline to allow you to share her thoughts on Isabelle's and her perspective as a nurse and as a sister in Isabelle's experience. Thank you guys very much, and please enjoy this conference.
Hi, everyone. As my mom said, my name's Maddie. I am a daughter, a wife, a mom, and I started my career in healthcare here at Children's while I was in nursing school, and I'm here today because Isabelle was my little sister. My mom kind of shared her story, but for those of you that do not know Isabelle, like my mom said, she had a mitochondrial disease, pseudo-obstruction. She required 2 transplants in her short life. At only 6 years old, she had a stomach, liver, small bowel, pancreas, and duodenum. And 2 years later, she received a kidney. Her transplants were her gift of life, and at such a young age, she was such a strong advocate for organ donation. But to me, Isabelle was just my little sister. She was spunky, smart, feisty, caring, thoughtful. She looked up to me as her big sister, but more importantly, I looked up to her. She was and still is an inspiration to me every day. She's always brightened up my day and put a smile on everyone's face. If you've ever had the chance to meet her, you know that she probably changed your life in some small way. Growing up, Isabelle was my best friend and constant playmate. So much of our lives did revolve around her health issues and being in this hospital. But she loved this hospital. In many ways, she did consider this place and the hospital staff to be her closest friends and family, which made the fact that she died following a medical error from this very hospital even more heartbreaking. Even today, 17 years later, it is still hard to put my little sister's death into words. I still struggle to comprehend how a routine blood draw turned into a medical error of giving Isabelle a fatal dose of IV potassium. I'm not sure how that could have happened. I often think about what I could have done to change it, what others could have done differently to have prevented her death. So I share her story with you in hopes that it enhances your vigilance and opens your heart to the impact that our medical mistakes can have. As hospital practitioners every day, it is everyone's responsibility to prevent medical errors like this from happening. Life is so different without Isabelle by our side now. Today, all of the most exciting moments in our life also have an element of sadness. My younger sister will never meet her. My husband will never meet her. My daughter, they'll only know her by the stories we tell. I know that life goes on and that it's normal for people to move on, but the reality is life didn't go on for my sister, so we live every day clinging to the memories that we have of her. I will always wish I could have my sister back. The pain and sadness of missing her will never go away, but I hope her death has taught someone something. I know it has taught me many things in my life and my career as a nurse. And so today, when you leave this conference, please try to remember that it's not just a medical error that you're working to prevent. It's a lifetime of small memories, little moments, laughs, smiles that are shared between sisters and family. Those can never be replaced. We all entered the healthcare field because we have a compassionate desire to help others. There's no doubt that you all make a difference every day in so many lives. But we ask you to never be satisfied, never grow complacent, and always strive to pay attention to the details because your vigilance can save one life. Thank you.
Thank you, Michelle and Maddie, for sharing Izzy's story with us this morning, and as you do year after year. We appreciate your continued support of this very special Grand Rounds, your continued support of all of our quality and safety work here at UPMC Children's, and your ongoing memory of Izzy and her impact on all of us and the work that we do here. So I thank you. I am honored this morning to introduce our speaker, Dr. Johanna Rosen. Dr. Rosen completed medical school at Virginia Commonwealth University, and she completed her pediatric residency and fellowship in pediatric emergency medicine here at UPMC Children's Hospital of Pittsburgh. Early in her career, she developed a special interest in quality improvement and patient safety, primarily through her role as a site liaison for the American Academy of Pediatrics Pediatric Septic Shock Collaborative, which brought together pediatric emergency departments to enhance sepsis outcomes through earlier recognition and treatment. And you're going to hear a lot more about her work in this today. But to enhance her expertise, Dr. Rosen then completed the Intermediate Improvement Science Series at Cincinnati Children's Hospital. And since that time, drawing on her experience and training, she's co-created the Patient Safety and Quality Improvement Curriculum for the Pediatric Emergency Medicine Fellowship here at Children's, where she coaches fellows in root cause analyses, guides them through improvement projects within the emergency department, and mentors countless fellows, residents, and other faculty as well, far beyond pediatric emergency medicine here at Children's. To that end, she is a 2023 UPMC ACES Award recipient. And for those of you who don't know, the ACES Award is the Award for Commitment and Excellence in Service, awarded to less than 1% of UPMC staff every year. So truly the cream of the crop. Dr. Rosen finds great fulfillment in collaborative teamwork. She's especially grateful for the opportunity to care for the children of Pittsburgh and all of our surrounding areas, along with all of her colleagues in the emergency department and throughout our organization here at UPMC and UPMC Children's. And I will add to that Dr. Rosen is a highly respected physician, a highly respected safety and quality leader here at Children's, QI project mentor, patient safety project mentor, clinician educator. So many residents, students, fellows, faculty who she's worked with, and I'm proud that I've had the opportunity to work with her and learn from her as well. So I thank Johanna for sharing her expertise with us this morning, and I'm going to turn it over to Johanna.
Thank you. I'm going to get my stopwatch on to make sure that I stay in time and my stool. so you all can see me a little better. Okay. First off, I just want to take a moment to thank you for sharing your story and for turning Izzy's tragedy into a movement for change. And I might get a little tearful here, but truly previous presentations in this lecture series have been inspirations for me. And I now find my career here really fulfilling. And I am just personally grateful to you for being part of my guiding light here. The title of my talk today is Incorporating Safety into Daily Practice, Sealings, Sedations, and Sepsis. I have no disclosures. So there's one thing that is in the way a little bit from what I can see here on my notes, so I'm going to move that over. But this presentation will describe how the Division of Emergency Medicine has incorporated patient safety into our daily practices by two avenues. One of those has been a grassroots approach where we dedicate 10 to 20 minutes either every month or twice a month to discuss safety concerns in our setting. And then the other is a more larger scale participation in national collaboratives to leverage the collective knowledge and experience in order to improve outcomes for children here, specifically with sepsis. So I'd like to start with our grassroots approach. We made this change about 10 years ago. We have medical staff meetings once a month. We cover all kinds of topics, including updates to clinical care, active research projects, PEDS emergency medicine fellowship concerns, even issues with faculty recruitment. And early in my career, our division chief at the time, Dr. Rick Saladino, agreed to start each of our meetings with a safety check. And we bring up this slide in our meetings to help everyone kind of get grounded. And we talk about this being a time that is a safe, confidential place to talk about our experiences, observations, maybe even our own missteps, with the goal of increasing awareness about the vulnerabilities in our care. And we may not find the solution to the safety problem during this meeting. Most of the time we don't, but we increase awareness amongst all the people that work in the emergency department. And then we do figure out the next steps in order to fix the problem. So one example is simple, but concerning and entirely unexpected in our setting, and does illustrate the importance of daily observations that may detect risk. So each of our rooms in the emergency department has one of these overhead ceiling lights that we can pull down and aim towards the patient for better inspection of a wound or to use during a laceration repair. And one of our attendings brought to our attention that not all of them are very sturdy and some of them were becoming frail. And one actually fell down when he was moving it into location. The child was not injured. He addressed it right away, and then he brought it to our attention during our safety checks. The overhead lights were subsequently inspected. Those that were damaged were secured up with zip ties, and then the ones that were damaged were replaced with these sturdier models. So just one example of an unexpected thing that came up during our ED safety checks. Now, a second topic that has been discussed on a few different occasions has been related to ED overcrowding, with the concern that patients may become sicker in the waiting room while we're working to evaluate and either admit or discharge the patients that are in our exam rooms. Sometimes when people encounter a busy waiting room like this, they may leave right away, or they may come in and wait for some time and then leave, and they leave without being seen. And we do worry that they may have required emergency care. So this happened at an especially high rate in October of 2022, when we saw nearly 8,870 patients. And our average typically is around 6,500. And that month, 10% of the patients left without being seen, when our typical rate was running around 0.4 to 1%. So it means that that month in October, nearly 900 patients left our waiting room without being seen. And we do worry that they may have needed care. So we've discussed this several times during safety checks, and in separate and several ED leadership meetings, it was decided to address this overcrowding in a few different ways. Before I proceed with this story, I want to orient you to this run chart. Along the x-axis is time moving forward from January 2022 to February of 2025. The primary y-axis on the left side corresponds to the number of ED encounters that we have each month, ranging from like just under 6,000 to nearly 9,000. The secondary y-axis on the right represents the percentage of children who leave without being seen each month. Our goal here is always 0. We do participate in a registry called the PCARN registry. PCARN stands for Pediatric Emergency Care Applied Research Network. And for this particular registry, there are 16 large pediatric hospitals that report data, and left without being seen data is one of the metrics that we use to compare and benchmark across sites. And for the PCARN hospitals, the left without being seen rate can vary from 2 to 15%. And CHP generally falls in the lower half, being closer to about 1 to 2%. So just some perspective there. So as mentioned, in October of 2022, we had that outstanding experience of having nearly 9,000 patients seek care in our emergency department, and our left without being seen rate was around 10%. One of the changes that we made to address this was to start a physician and triage process. That's the PIT. We started that right in October. And this allows the children in the waiting room to have physician eyes on them to address their concerns and to start evaluation. For example, if the patient needs an X-ray as part of their evaluation or an ultrasound, that can be ordered in the triage area. And then we also have treatments available like antipyretics for fevers, Zofran for nausea, vomiting, and currently we also have albuterol and dexamethasone readily available in triage for asthma exacerbations. Around that same time in 2022, we activated our surge plan. This is a moonlighting plan for physicians who can volunteer to come in the late evening and overnight hours in order to help us see the many patients that are waiting to be seen. And then in February of 2023, we opened an area called the Blue Zone. So the Blue Zone is an additional 5 to 10 patient care locations adjacent to the emergency department. Some of the year it's open on Mondays, which is our busiest day. It could be open at 11 a.m. Other parts of the year, we open it in the evening time when the local express care closes and more children seek care in our emergency department. So then finally, in September of 2024, in anticipation of more patients coming to seek care, we activated all 3 of these programs in addition to dedicating one of our emergency department nurses as a discharge nurse. So this nurse can take time to review discharge instructions with families. So in the emergency department, I see a lot of you don't necessarily work in the ER, but our common practice in the emergency department is for the resident or the attending physician to go over discharge papers and provide that teaching. Whereas I think in the hospital, that's often a nurse role. But we adopted the nurse role in the emergency department to help free up the residents and attendings to take care of the other patients and to see the new ones who need to be seen. So with all of these efforts in place, currently we're at about a 1 to 2% left without being seen rate, and we have not risen above 4%, even when we've experienced surges in patient volume. So during safety check, a third topic that often comes up is related to medication administration. People over the years have expressed uncertainty over epinephrine dosing in preparation, especially shortly after the pandemic or during the pandemic when we had a lot of turnover for our nurses and new people learning. Epinephrine can be a scary medication to draw up quickly and deliver in a safe manner. Other physicians have described longer than desired wait times for important antibiotics like cefepime or levofloxacin that we aim to have administered as soon as possible for children with cancer and fever, for example. Others have expressed concerns about Zofran and ketamine being mixed up during sedations. Those are 2 medications commonly given during our sedations. And then weight documentation in pounds versus kilograms comes up periodically. So that's my child when he was 4. Does he look like he's 33 pounds or 33 kilos? And again, 33 kilos is about 65 pounds or so. So 2 changes we made, among others, to address these issues were starting to use a paper copy of a safety checklist during sedations, and adding a pharmacist to our emergency department team. But first, I want to describe to you this checklist. We started using it about 4 years ago, just on paper. This is not officially in the EMR yet. But we have several trainees in our setting that rotate through a series of shifts in our emergency department, and some of them may be dedicated to performing procedural sedation. They all receive training, simulation training at Weiser, but that training may be months before they're actually in the department performing sedations. So we like to push them to use this checklist with these helpful reminders, and many of our attendings use it as well. It includes information about Zofran to make sure that that has been given already, or to pause and give it at that step in the checklist. And it also calls for a review of the patient weight and planned doses of ketamine to be used. I personally, in the top corner, will write the weight in kilos and in pounds and ask the parent who's present, does it sound about right that your patient or your child is 60 pounds when we have 30 some kilos? So in my personal experience with using this checklist is that my individual adverse event rate has dropped to nearly 0. In April of 2023, we had a great save captured by use of this safety tool, and we advertised it to our division. So during one of our sedations, the physician was running through the sedation timeout checklist and stated the patient was 42 kilos. People recognized that the weight was too heavy for the child sitting in front of them. They stopped the process, they reweighed the patient, and the child measured at more like 20 kilos. And so the nurse redrew the ketamine at the more appropriate doses, and then the timeout was restarted. And this was an important save because with ketamine in particular, twice as much as desired could have resulted in apnea and the need for assisted ventilations, and in worst case scenario, an intubation. And that's never our goal in procedural sedation. So this was a really great check, safety check that was detected by use of this checklist. So finally, also during our safety checks, several people have discussed the use of end-tidal CO2 monitoring to enhance our safe practices. End-tidal CO2 can detect breathing before pulse oximetry can. And thanks to the persistence and perseverance of our medical director, Kavitha Kanthi, and our leader, Ray Patetti, we now have everything that we need to use end-tidal CO2 monitoring during sedations. And this will be especially helpful for patients who may need to be in that lateral decubitus position for drainage of a pilonidal abscess, for example, or perhaps during a lumbar puncture. Now, I do want to say one of the most important changes that came out of safety checks in our emergency department was the drive, I think, to advocate for a dedicated pharmacist in our emergency department. The hospital listened to our concerns, reviewed medication safety events in our setting, and supported the creation of an ED pharmacist for Children's Hospital here. So Erin Tamulonis is here. She joined us in 2023 after finishing her training here. And she's been one of the best things for our emergency department. She's helped us with all kinds of things. And when I ask people to tell me what Erin has helped them with, this is just a sampling. But she was very instrumental when we were having our epinephrine uncertainty and uncomfortability. She would help in real time with dosing and medication preparation. When there's a code and we need code meds prepared quickly, we don't even have to ask. Erin is right there with the code box in the room ready to go. She's also helped us with continuous drip dosing and preparation, with timely antibiotic administration. When we had our IV fluid shortages, she's helped us understand what those meant and what was available to us. Some of our children have chronic medical conditions and have important home medications, and she will help us with review of those and doses and whether or not we need to give them while the patient's in the emergency department. She has also helped with TPN fluid composition, which isn't something an ER doctor really wants to think about because that's a longer term management and kind of complicated. And finally, she has helped us with clinical effectiveness guideline creation and updates. So we are so happy to have Erin Tamulonis on our team. And I do think that the frequent discussions during safety check have been part of the advocacy to create her position and have her here. So, those are some examples of how we have incorporated patient safety into our daily practices by facilitating regularly scheduled open discussions about our vulnerabilities. And another avenue for promoting safety can be to join a national collaborative, especially one within quality improvement. This allows any one hospital or unit to leverage that collective knowledge and expertise from a group of healthcare employees with a shared goal. And we started this under the umbrella of pediatric sepsis at the level of partnered emergency departments. And then we spread those lessons learned and those successes to include the acute care floors here at Children's. And then we've even reached out to other emergency departments within the UPMC system to spread some of this knowledge and good work. So why sepsis? Why are we talking about sepsis in a patient safety conference? Because sepsis is often sneaky in kids. It may be difficult to detect. The diagnosis may be missed or delayed. And especially in the emergency department, where we're seeing lots of kids with fevers each day, finding the one that's going to progress to sepsis or septic shock is not easy. Some children may be misdiagnosed as having a benign viral fever, and then they may not receive antibiotics in a timely manner and run the risk of deterioration. So while sepsis can feel like looking for a needle in the haystack, it is a leading cause of illness and death for children in the United States. There can be up to 42,000 cases annually, and 5 to 13% of those children will die, which is like saying 1 in 10 of these children may pass away from sepsis. And if we detect it early enough, death from sepsis is preventable. So when is early enough? That's a little hard to answer specifically, but in general, we like to operate under the approach of sooner is better. I do want to point out researchers are learning more and more about how to specifically identify sepsis and define sepsis and septic shock. But for the purposes of those of us that work in the emergency department or at the bedside on the acute care floors, I do like to use this graphic that I created based on Goldstein's definitions from 2005. I like to describe sepsis as a spectrum. On the mild end of disease, we can think in terms of SIRS, which is alteration in vital signs, plus minus an elevated or low level of white blood cells. And then sepsis can be considered SIRS plus a source of infection for that particular patient. Severe sepsis can include signs of organ dysfunction, like a delayed cap refill, altered mental status, maybe elevations in LFTs or a lactate level. And then septic shock includes specifically cardiovascular dysfunction with hypotension despite IV fluid resuscitation. So, an altered mental status and hypotension, that typically septic patient is kind of late in disease. And once they've reached this level, they're at a much higher risk of passing away. So we do hope to detect this earlier. And in order to detect sepsis earlier, we have to rely on more subtle signs, things like abnormal vitals, and then also maybe the presence of a high-risk medical condition. Examples of those can include a patient with cancer whose immune system is not functioning appropriately, maybe a patient who has a central venous line that may be a nidus for bacterial growth, or taking immune suppressive drugs for an organ transplant. So how can we work towards detecting sepsis sooner and improving these outcomes? We can operationalize screening for pediatric sepsis by joining a collaborative of hospitals, learning from each other with a shared goal. In 2013, we did just that by joining the AAP's Pediatric Septic Shock Collaborative. That collaborative began in 2011 under the AAP's section of emergency medicine. And this was around the time that several of those collaborative group members were publishing their promising findings over the recent years. So Andrea Cruz is a pediatric emergency medicine physician, and she and her colleagues at Texas Children's reported how implementation of goal-directed therapy for children with suspected sepsis in the emergency department could reduce time to their first fluid bolus and to their first IV antibiotic. While Git Larson and colleagues at Primary Children's in Salt Lake City showed that standardizing screening and treatment, specifically in the triage process, could also reduce time to fluids and antibiotics. And their study showed that they could decrease hospital length of stay from about 7.5 days down to 5.8. So these findings helped fuel the PSSC, and we joined 24 other emergency departments to help standardize our screening and early treatment processes. So what did participation look like? I will say it was a lot of learning and making mistakes and learning more along the way. We spent around 8 months submitting baseline data and developing and distributing educational materials to our staff. Where did we start? Well, our baseline outcome measures were examined over a 12-month period. The two outcome measures that we checked were mortality rate and then rapid transfers to a higher level of care. So the mortality rate was 2% at that time for us. And rapid transfers of care, specifically what that means is a patient who's evaluated in the emergency department for presumed sepsis or septic shock is seeming to do well enough that they could be admitted to the acute care floor, but then end up being transferred to the ICU within 12 hours of that admission. And our rate at that time was 12%. So for our baseline process measures, these were evaluated over a 3-month period, and only about 46% of our patients received their first fluid bolus within 20 minutes of recognition, and only 18% received their first antibiotic within 60 minutes of recognition. So during and after baseline data submission and working on educational outreach, or part of our educational outreach included creating a badge tag and then developing our first EMR tool, which was a power plan, basically a standardized order set. So this is what our badge tags looked like. Again, about the size of your badge, something that you could include with your badge. And it's basically a pediatric sepsis screening tool shrunk down to this size. It was based on the previous research as mentioned and included the screening tool specifically includes a combination of vital signs, physical exam findings, and the presence of high-risk medical conditions, like I mentioned. The flip side of the badge had age-based vital sign thresholds for sepsis screening, and we went ahead and calculated the minimum systolic pressure so people don't have to do that math in their head with the 70 and the 2 times the age and whatnot. So we could just look at the badge and see if their vital signs surpass thresholds. We distributed this badge to all attendings and nurses in the emergency department who care for patients. And then our first EMR tool was a power plan, and that's our local terminology, as you all know, for a standardized order set. And this can be found on our homepage of the mini order sets and power plans that we use in the emergency department. The ED septic shock power plan has orders for diagnostic tests, for treatments like the recommended antibiotics, and also for vasopressors, which has been really helpful for us because not any one ER physician orders a vasopressor for every shift. It's not a common thing to order. So having that guidance within the power plan has been helpful. Now, about 1.5 years after joining the PSSC, we then got our automated alert in the form of a tracking board icon that was ready to go in FirstNet in around March 2015. And then we also created a screening form in the EMR. At that time, we were asking the physicians to screen and document that screen in a power form. And we have since moved to the nurses fulfilling that role. I'd like to acknowledge both Scott Coglio and Lisa Meyer, who were really crucial and instrumental to creating these tools in our EMR. So this is what our tracking board looks like in the emergency department. Each row is for one given patient, and under the patient care column, we have lots of icons that mean either there's a task to be done or something was already done and is finished. And the lightning bolt is what's circled there in blue with the blue arrow. That will appear automatically if a patient is hypotensive for age, or if heart rate, respiratory rate are above or below or beyond the sepsis screening threshold. So 2 of the vital signs being abnormal or hypotension alone, the bolt will appear, and that's an indicator for us to complete the remainder of the sepsis screen with the physical exam findings and the possible presence of a high-risk medical condition. One of the lessons learned the hard way is that this often overfired for generally healthy teenagers who were anxious, or those who were having an asthma exacerbation, because they would be tachypnic and tachycardic. So we ended up increasing the heart rate threshold for teenagers by about 20 beats per minute to help reduce that alert fatigue. The bolt still currently fires frequently. It's every month. It's 1 in 18 patients that we see in the emergency department will have a lightning bolt. And the majority of them do not have early sepsis, but we have battled against that alert fatigue by celebrating great catches. Mel, many years ago, would at our division staff division staff meetings would highlight lightning fast champions and would name specific people who did a good job at getting fluids and antibiotics to patients in a timely manner. And then we also share data to help people recognize the importance of our EMR alert. So this is an example of the data we've shared to our team. This is a control chart that illustrates our median time to antibiotics for children with suspected sepsis. It's similar in structure to a run chart, but has added information about the variability in the data. So again, the anatomy of this chart, the x-axis is time moving forward from November 2013 to November 2016. The y-axis is time in minutes, and then each data point represents the median time to the first IV antibiotic for the children with suspected sepsis during that month. CL is the center line, which is generally representative of the average. UCL is the upper control limit. LCL is the lower control limit. These are limits that tell us about the variability in the data, and they're based on 3 standard deviations from the average. So ideally, if your process is in really good control, your control limits are narrow rather than wide. So you want very little variability in your process. Within about 6 to 8 months of having the Bolt alert that we started there in March of 2015, we were able to share that the screening process reduced time to antibiotic administration. So our previous average was around 97 minutes, and we were able to get down to 70 minutes. And as you can see, the control limits are a little tighter than they were before. Any questions about this? Okay. I love this stuff, but all right, so following educational outreach, some EMR builds for the order set and our automated alert, and while sharing our successes within our division, we published the clinical effectiveness guideline on the InfoNet with a 1-page algorithm for easy guidance, especially for the many trainees in our setting. And this is what that first version of our guideline algorithm looked like. It was designed to be a 1-page tool to help walk the residents and other trainees through the process. On the right side is what goes into screening a patient. And once they've screened positive and you're at the bedside with your attending thinking, well, this could be early sepsis, then it walks you through the steps and how quickly you should get those things done. So the result of all this hard work, this collaborative of emergency departments working within the PSSC, we collectively showed that having a screening tool, a standardized order set with goals for timely interventions, and by sharing lessons learned from site to site, we collectively reduced the 30-day mortality from sepsis from 2.3% to 1.4%. And building off of those successes, we started to spread these lessons learned to the acute care floors. And this was part of a new collaborative that pretty much everyone in the PSSC went on to the IPSO collaborative, that stands for Improving Pediatric Sepsis Outcomes. And this was a group managed by the Children's Hospital Association. We joined them in 2017. And this is when Gabriella Butler and Adrian Marcinek from Health Informatics and Chris Horvat from the ICU really took the lead. Holly Warmus was instrumental. She was from the acute care nursing side. Lauren Alessi and Matthew Valenti, both at that time were working with PHM, helped incorporate pediatric sepsis screening on the acute care floors. And then Vikram Raghu at the time helped us examine delays in antibiotic delivery in the acute care floor setting. And he partnered with pharmacy and IT to create an expedited process such that the pharmacy is alerted, I believe via page, that there's an antibiotic that needs to be prioritized for preparation and delivery to a child with suspected sepsis. And that work was published. I should have included that here, but here's another timeline that I just want to share with you because it summarizes a lot of the hard work that we've done here at Children's under the umbrella of pediatric sepsis. So like I mentioned, back in 2013 and 15, we were part of that emergency department collaborative. By 2017, we moved on to IPSO and we started screening patients. Holly worked on 7C just with paper screening at first. Twice in, I think, every 12 hours during nurse leadership change, clinical leader change, they would screen on paper and see how that was working. By 2018, we had an acute care sepsis pathway on the InfoNet written by Lauren Alessi and others. We had a standardized power plan to be used in the acute care floors. We also had an EMR alert system such that when vitals are charted and abnormal on the floors, the nurse leader telephones ring to say a sepsis screen needs to be completed. The nurse will complete the screen and then reach out to the residents or attendings if the screen is positive. We also have now in our EMR standardized forms to fill out to track all this information and to track clinical care for each patient. By 2019, Gabriella and her partners created a dashboard that can give us, or does give us, daily reports on how we're doing in this area. And that pharmacy alert that I mentioned was ready to go in 2019. And then, 2020 was a different year for all of us. Once we kind of got through the pandemic times and realized that we were doing really great work here at Children's, we started reaching out to other hospitals in central PA, specifically like the Harrisburg emergency departments, and partnered with a couple emergency physicians there to create a standardized order set for children with possible sepsis. We have a skeleton version of an EMR alert system. The central PA system already functions under Epic. That was put on pause because of the Bridges transition, but we've got work ready to go in terms of the new version of Epic. We've got a skeleton version of a best practice alert that may help all of our hospitals within UPMC. In 2024, Chris Horvat and I began working with core Cerner sites. So those emergency departments like Presby and Shadyside, among others who still operate under Cerner, they have adult sepsis screening and protocols there. And we worked with them to create a pediatric specific power plan that can be used at those emergency departments and a screening process for children that may be seen in their emergency departments. And then this year, as part of the Bridges transition, Chris and I are working to make sure that all of these gains made here are not lost and that we can still have screening and standardized order sets and all the tools that we need in Epic when the time comes. So there is a specific pediatric sepsis work group within the Bridges work. So getting back to IPSO and the successes of all this hard work, the collaborative published our findings in 2023, and this was based on more than 20,000 children with suspected sepsis. We found that bundle compliance reduced 30-day sepsis attributable mortality from 1.4 down to 0.9%, which is a 35.7% reduction over time. And the IPSO bundle of care is basically these three elements, having some sort of recognition tool. So either an EMR alert, a bedside huddle, or a standardized order set. We here like to have all three of those components as recognition tools, but some hospitals may only have one or two. The other part of the bundle is to have a bolus delivered within 1 hour of recognition. And we did find that mortality was most dependent on antibiotics delivered within 3 hours rather than 1 hour. We still operate under ideally within 1 hour, but the data shows that the 3-hour time period does help reduce mortality. So the IPSO collaborative currently houses a dashboard where we can see how we compare to other hospitals across the country. And this was just pulled up a few days ago. So our current 3-day mortality is 0.3%, which is 78% below our peers in this collaborative. And then our 30-day sepsis attributable mortality is at 0.8, which is also about 70% less than our peer hospitals. And out of all this, we rank 4th amongst 25 hospitals. So we're doing a really good job here by leveraging the knowledge and expertise from this collaborative and performing very well. We also perform well when it comes to hospital utility and costs. So our median hospital days for sepsis cases is around 6 days, which is equal to the other hospitals. And then for those kids that require ICU care, our mean ICU days is around 7.8, which is just below our peers. And then wage adjusted cost information per case, any one patient may we may spend more than $100,000, but this is 22% below our peer hospitals. So doing well with performance and with utility and costs. See how we're doing on time. Okay, so I just want to say, I hope that my stories about our experience in the emergency department have helped you appreciate that there's like 2 different avenues to incorporating patient safety into your care. One could be like a grassroots sort of thing where you're just talking to people on the ground who are doing the work and having that dedicated time. It doesn't need to be long. It could be 10 to 15 minutes once or twice a month just to talk about what the experiences have been can really help drive improvement. And then the other is to leverage all the collective knowledge and expertise by joining a collaborative and seeing how you can work towards a shared goal that will promote patient safety. Both of these approaches have helped us foster safety and improve outcomes for our patients in the emergency department. I just want to take a few moments for some concluding remarks. Part of the reason that I really like patient safety is that we have to understand that humans are fallible. A lot of us are type A. We want to be perfect. That's how we got into nursing school or med school, or we've been successful. But mistakes do happen and humans are fallible. It's in our nature. I've been there myself. But it's really important that we just understand that and identify risks. And then design our practices, our settings, our whole systems to support all of us like kind, smart, compassionate people to care for our patients in the best way possible, avoid patient harm and improve outcomes. Any questions? I want to thank everyone for your attention. These are a bunch of people who've been instrumental to this work. Kristen Sandridge is here, Ray Patetti, Kavitha Conti, Mel Tavares, lots of others. Megan Clapp has helped. She helps us review our patient safety events and identify routes to problems. Any questions? Okay. Great.